Hey friends, slide a little closer to the screen, pull that blanket up to your chin, and before we dislocate your expectations as badly as medieval surgeons dislocated actual limbs, tap the like button, jab subscribe, and tell me in the comments what time it is where you're listening. I love seeing who's drifting off at 2 a.m. in Brisbane versus 9 p.m. in Boise. Fan on? Lights dimmed? Great! Let's loosen the joints of history together. This is where we, sitting safely in the 21st century, instinctively wait for the countdown. All right, I'm giving you something to knock you out. That moment never arrives. Anesthetic gases won't whisper onto the scene for another 5.5 centuries. Instead, you get quick-fire distractions. Swig of ale, pinch of henbane seeds, maybe a prayer sketched on your forehead in soot. But when Aldred grips your wrist and pulls, the pain punches through every primitive remedy like a battering ram. Your vision whites out. Somewhere distantly, you scream. Why perform such torture while the patient is awake? Because until the 1840s, surgeons had no reliable way to dull agony besides alcohol, opium, or a blow to the head, and none of those guarantee cooperation, especially during delicate realignment. So medieval bone setters honed a brutal efficiency. Work fast, work firm, and get the fracture aligned before shock, blood loss, or the patient's fists stop you. But let's rewind. How did humanity discover bone setting in the first place? Archaeologists have found healed fractures in Neanderthal skeletons, evidence that our ancient cousins practiced some form of splinting 50,000 years ago. Fast forward to 2600 BC in Egypt, where papyrus scrolls describe wooden splints wrapped in linen soaked with resin, basically ancient fiberglass casts. Hippocrates in classical Greece formalized traction methods, instructing students to hang weights from dislocated shoulders until joints slipped back home like reluctant tenants answering an eviction notice. By the Middle Ages, Europe's medical knowledge was a patchwork quilt of Roman texts, Arabic translations, folk remedies, and battlefield experience. University-trained physicians debated Galen, but peasants couldn't afford scholarly egos, so they relied on village bone setters, craftsmen, midwives, blacksmiths, anyone with strong hands and a tolerance for screams. Their techniques passed orally from mentor to apprentice, sprinkled with superstition. Whisper Psalm 31 while tugging a leg. Set an arm during a waxing moon so the bone grows with the lunar cycle. Aldred subscribes to a little of everything. First, he realigns your fracture in one decisive yank. Then he slides slats of willow against your arm, binding them tight with wool soaked in egg whites, nature's epoxy. Finally, he recites a charm, half Latin, half nonsense, to ward off bone dragons that supposedly gnaw at fractures from the inside. Call it placebo, call it faith, but studies of placebo today show beliefs can dampen pain pathways. In 1284, ritual is the only analgesic within reach. Let's pause to breathe together. Inhale through the nose, exhale through the mouth. Because the scene we're sitting in is thick with contradictions, compassion wrapped in cruelty. Aldred doesn't want you to suffer, he simply has no alternative. Speed is mercy. The longer he hesitates, the more muscles spasm, the harder the bones are to align, and the higher the chance you'll be permanently crippled. So he becomes ruthless on your behalf. Okay. Splint secured, charm muttered, now comes aftercare. No antibiotics yet. Penicillin waits until 1928, so infection is the big bad. Aldred packs the limb with mashed garlic and honey. Both have mild antibacterial properties. Then he rigs a sling from burlap. You'll sleep near the hearth where smoke keeps flies off open wounds. Every few days, his apprentice will change the dressing, sniffing for that sweet rot odor that warns death is congealing under the skin. If that smell blooms, the next episode of our gruesome miniseries is amputation. But that's a plot twist for another night. You might be wondering, did bone setters actually succeed? Surprisingly often. Anatomy is forgiving. Line the pieces up and immobilize them, and bone will knit. Skeletal remains show countless medieval fractures healed in decent alignment. But when bone setters failed, when splints were too loose or infection crept in, the results were horrific. Limbs twisted like gnarled branches, joints frozen, or sepsis spiraling into fatal fevers. Every reset was a coin toss, weighted by luck, skill, and the patient's own immune system. Now, let's widen the lens beyond this smoky cottage. Across Europe, guilds of barber surgeons handle bones on battlefields. Picture Agincourt, 1415. Arrows whistle, men collapse, and surgeons dart among them with saws slung at their hips like lethal handbags. There's no time for bedside manner. They grasp shattered legs, traction hard, splint faster than a blacksmith shoeing a horse, then rush to the next groaning pile of armor. Amid mud and blood, they refine practical shortcuts. Leather tourniquets to staunch bleeding, metal forceps to fish arrowheads, cauterization irons heated cherry red to seal vessels. Their battlefield lessons trickle back to civilian bone setters, raising the overall success rate in peacetime. Meanwhile, in the Islamic world, scholars like al-Zahrawi publish illustrated manuals showing step-by-step reductions, wrapping fracture ribs with tight bands, suspending arms in traction. Translated into Latin centuries later, those diagrams give European surgeons a visual cheat sheet. Medicine, even at its most brutal, is an international syllabus of pain management tips. But remember, no anesthetic. Patients grit teeth, pray, faint, or vomit. Some bone setters hire strong men to hold people down. Others exploit the body's own shock response. A swift strike to the jaw or a twist of the ear, flooding the brain with endorphins milliseconds before the main event. Primitive, yes, yet conceptually not far from modern counter-irritation techniques where nurses pinch skin while inserting needles. Pain, in these centuries, is not merely a sensation, it's perceived as moral currency. Many clerics preach that suffering purges sins, aligning the fractured soul as bones are aligned. So when patients howl, onlookers sometimes nod with grim approval. The body is being chastened toward salvation. Imagine the psychological weight. You're terrified, racked with agony, and everyone around assures you this is spiritually good for you. Aldred's whispered charm doubles as absolution. Fast forward to year 6 of your new injury-dominated life. If the bone healed straight, you'll regain almost full function, though chronic ache may linger like a rude houseguest. If it healed crooked, you adapt. Fingers tingle in winter, joints grind like millstones. But you keep shearing sheep, because employment contracts don't include disability clauses. A misset limb brands you forever. People recognize survivors by their gait, their hooked wrists, their stories told around alehouse fires. In a weird way, scars become currency too. Proof of resilience, of having walked through the furnace and come out singed but whole. Let's teleport for a moment to Ming Dynasty China, where bone setting is elevated to an art within traditional medicine. Practitioners study chi flow, but they also build sophisticated splints from bamboo, using silk cords for traction. They massage muscles first, tuina, to soften resistance, then rotate bones with a finesse our gruff English Aldred would envy. No anesthesia here either, but acupuncture needles prickle along nerves, releasing bursts of endorphins that shave the pain's edge. Across the globe, different cultures improvise analgesia with the tools they trust. Coca leaves in Andean highlands, kava in Pacific islands, peyote among some North American tribes. Yet, everywhere, the central act remains the same. Set the bone fast, pray it holds. Back in Europe, Renaissance anatomists dissect cadavers in candle-lit chambers, mapping muscles onto vellum. Their findings trickle down slowly to street-level bone setters. By the 17th century, you'll find manuals with woodcuts demonstrating leverage points, like Delaboy Silvius's treatise showing how to use a chair back to reset a shoulder. But until Ether's first public demonstration in 1846 Boston, patients stay awake for all of it. Now, friend, unclench your jaw. You've been holding it tight in sympathetic pain. Roll your shoulders, feel the miracle that is an intact skeleton, and be grateful for the dull buzz of modern dentistry drills compared to handsaws on tibias. History is a dark theater, but knowing what our ancestors endured can make the present feel like a feather bed. Before we dim the torch for tonight, do me a favor. Drop a comment telling me which part of this journey shocked you most. The leather bite strap, the egg white casts, or the idea that pain itself was considered divine chemo. And share the video with someone who thinks they're tough. Let them test their courage imagining a compound fracture reset by candlelight. I read every comment, and your stories keep this channel alive like marrow keeps bone alive. Slide your feet a little deeper under that blanket, because we've traded the smoke-choked cottage of Master Aldred for the bright, fish-tated air of Tudor England, and things are about to get loud. While you're settling in, thump that like button like a blacksmith hammering hot iron. Jab subscribe if medieval medicine makes your skin crawl in the best way. And drop a comment telling me whether you'd trust today's street surgeon with your collarbone. I'll be reading while sipping something stronger than willow bark tea. All right, deep breath. The fair is in full swing, and every jangle of a peddler's bell is competing with screams from the bone quack's stall. Picture a marketplace outside London, spring of 1536. The stench of ale, roasting eels, and wet straw rides the morning breeze, mingling with the metallic tang of river mud. Pickpockets work the fringes, bear-baiting drums pound in the distance, and smack in the middle of this carnival stands a makeshift platform under a red canvas awning. On it, Mistress Joan Snapknuckles Tilney, a bone setter whose reputation travels faster than wagon wheels. She's broad-shouldered, sleeves rolled, wrists corded with tendon like mooring ropes. In an era when women are banned from university medicine, Joan turned exclusion into niche marketing. If the barber surgeon turns you away, the widow Tilney will put you right, no questions asked, and cheaper. She's flanked by 2 burlap sacks stuffed with splints, bandages, and ominous wooden wedges. A signboard painted in bold letters booms her sales pitch. Bone set while you wait. A shilling per limb, half price for children. Guarantee the limb will be straighter than a Puritan sermon or your money back, assuming you live to collect. Beneath the jokes, there's desperate faith. Sailors with busted fingers. Field laborers nursing greenstick fractures. Maidservants whose masters won't pay for a licensed surgeon. Joan is their last stop before lingering disability or the workhouse. Her first customer today is a drover who tripped under a beef carcass. His ankle bulges, the joint ballooned like dough. Joan doesn't whisk him behind curtains. Spectacle is free advertising. She slaps a stool center stage, hoists his leg onto her lap, and starts palpating the joint with the focus of a jeweler inspecting flaws. The crowd leans in. Somewhere, a lute player hits a sour chord, as if on cue. Joan's apprentice, a nimble boy named Kit, whips out a clay mug of strong cider. "Drink deep, good sir." Alcohol remains the only pre-procedure concession, and the drover gulps until foam drips into his beard. Now here's where Tudor ingenuity steps in. Unlike Master Aldred, Joan uses a traction device she calls the boot jack, a wooden frame with adjustable pegs and a crank. Kit slides the man's foot into a padded sock attached to the frame, then tightens a screw until tendons stretch taut, separating the damaged joint surfaces just enough for a clean reset. It's crude biomechanics, but surprisingly scientific. Create space, reduce muscle spasm, then guide bones home. The drover bites his sleeve, his eyes water, but he doesn't shriek yet. Joan feels for alignment, nods once, then jerks the heel. A crack rings out, crowd gasps, pigeons scatter from the church roof. Joint settled. You can almost hear Elizabethan orthopedics earning another testimonial for the price of a beer. Joan splints his ankle with willow slats, wraps linen soaked in boiled cowhide glue, it hardens like plaster, and finishes by daubing green ointment of comfrey, nicknamed knitbone because herbalists swear it speeds healing. Modern pharmacology says comfrey contains allantoin, a compound that indeed promotes cell growth, though heavy doses can wreck your liver. Tudor England cares more about walking tomorrow than liver stats at 40, so comfrey it is. The drover staggers away, cheers rising behind him, and coins jingle into Kit's purse. Spectacle sells, and fear is the best promoter. Snapknuckles runs her practice like theater, but she's dead serious about skill. She apprenticed under her father, himself a veteran of the Cornish tin mines, where broken limbs outnumbered paydays. She's memorized which poles realign radial fractures versus which shatter them. She knows infection is the grim reaper in disguise, so she washes her splints in scalding brine between patients, an advanced concept a century before Semmelweis will rave about hand-washing. Still, hygiene is relative. The same hands that scrub infection also take silver directly from customers, then rummage through pus-streaked bandages. Microbes don't care about good intentions. When wound rot sets in, Joan brews a poultice of moldy bread, spider webs, and vinegar. Sounds grotesque, right? Surprise! The mold may contain penicillium strains. The webs deliver vitamin K. Vinegar lowers pH enough to slow bacterial growth. Folklore stumbling into biochemistry decades before microscopes. Let's swivel from the fairgrounds grit to the palatial hush of Greenwich, same year. Henry VIII is thundering through corridors, one hand clamped to his thigh where a jousting accident left a festering bone-deep wound. His court physicians, credentialed, berobed, Latin quoting, have packed it with goose fat and rose oil to little effect. They squabble over whether humoral imbalance or sinful dietary excess caused the infection, while the king's leg swells and his temper detonates hourly. Across town, Joan resets ankles for groats, but Henry's life may depend on similar mechanical common sense none of his learned doctors will dare suggest. Drainage, realignment, splintage. When the king's wound finally erupts with evil pus, rumor spreads among London's lower classes. If only the old bone quack in Cheapside could reach the palace, she'd lance it, clean it, bind it, and have His Majesty dancing by Michaelmases. Of course, protocol forbids summoning a commoner woman to treat a monarch. Yet history whispers that one unnamed wise woman was escorted in secret to advise the royal surgeons on simple drainage. Maybe that was marketing legend, maybe the seed of truth, but it highlights how bone setters shaped medicine from the margins, forcing elite physicians to reconsider hands-on practicality. Let's zoom in on Joan's toolkit, because every instrument tells a story. First, the Hippocratic bench, a portable version she built from oak with leather straps. Patient lies supine. Pulleys at head and foot apply countertraction, aligning long bone fractures with slow, relentless tension. Modern orthopedics still uses traction tables built on the same geometry. Next, a collection of thick goose quills trimmed into funnels. She packs open fractures with honey-soaked linen, then dribbles wine through the quill, flushing debris without opening the dressing. Early irrigation technique. Finally, a jar of powdered mummy, imported from Egypt, or so the spice merchant claims. Tudor England believes ground mummy contains life force. Joan mixes it with egg whites to seal compound fractures. Placebo? Absolutely. But the protein congeals like paste, creating a rudimentary scab. Pain, once again, remains the screaming elephant in the room. Alcohol helps. Opium tincture, laudanum, exists but is expensive. So Joan supplements with mind games. She employs a hurdy-gurdy player to churn out hypnotic drones, encouraging patients to focus on rhythm instead of agony. Neuroscience today calls it gate control theory. Competing sensory input can dampen pain signals. Elizabethans just call it a good tune while bones snap. Night falls on the marketplace. Torches hiss in damp wind. Joan's last case of the day is a little boy whose forearm snapped under a cartwheel. The fracture is green stick, bone bent inward like a snapped sapling, but not fully broken. She knows children's bones remodel magnificently if you get the angle right, but misalign and he'll carry a banana-shaped arm for life. She immobilizes him against his mother's chest, hums a lullaby while palpating the curve, and in one gentle motion straightens the bend. The boy yelps, then sobs into his mother's shawl. Joan's apprentice slides a sugar plum between his lips, an expensive bribe, but worth the reputation. Childhood fractures heal quickly. By midsummer, he'll be racing around again. Proof that the bone quack outperformed the university doctors who wouldn't treat peasants anyway. Now, you and I know we're speeding toward the 17th century's scientific revolution. Anatomists like William Harvey will trace blood flow. Cartesian philosophy will separate mind and body, and eventually, chemists will isolate ether, letting surgeons knock patients unconscious. But here in Tudor streets, you witness the missing link: empirical pragmatism, bridging guesswork and science. Every reset Joan performs becomes a tiny data point. If a particular splint fails, she modifies. When a garlic honey poultice rescues a wound, she commits the ratio to memory. She's running a clinical trial without charts, guided by survivorship bias and gossip. That brings us to documentation, or lack thereof. Barber surgeons kept casebooks, but many bone setters couldn't write, so their knowledge traveled orally. Yet one rare manuscript survives, the Tilney roll, a parchment strip Kit started compiling, sketching stick figure diagrams of joint manipulations with notes like, for the shoulder displaced forward, stand behind, grasp elbow, lift and roll backward till a clack be heard, give ale. Those doodles will later inspire a 1625 pamphlet that university men dismiss as folk nonsense, only to rediscover the same maneuvers centuries later and formalize them as Kocher's method. History loves an underdog. Let's rove north to the Scottish Highlands, where clan healers practice their own brand of bone setting, lapping. They swaddle fractures in layers of moss, raw sheep's fleece, and whiskey-soaked cloth, then wrap with bark strips. The moss absorbs moisture. The lanolin in fleece keeps skin supple. The whiskey disinfects. Patients convalesce in smoke-filled bothies, taking heather tea laced with foxglove, digitalis, which slows heart rate, easing pain. Toxic, yes. Effective, also yes, if dosed carefully. Oral tradition warns, pick foxglove at dusk lest the leaves kill quicker than they heal. That's pharmacology disguised as folklore. Pain is still front and center. Some Highlanders bite on a carved rowanwood stick inscribed with protective runes. Others slip into trance through rhythmic chanting. Anthropologists call it cultural analgesia. Shared belief rewires perception of pain. Modern MRI studies show chanting or prayer can indeed release endorphins and modulate the anterior cingulate cortex. Medieval folk didn't know brain anatomy, but they knew singing together made the hurt less sharp. Imagine Jones' hurdy-gurdy track heading north, merging with bagpipes. The soundtrack of survival. We can't ignore the grisliest scenario bone setters face. Compound fractures with bone protruding. In Tudor doctrine, exposed bone invites foul air that breathes infection. So the priority is shove it back in and seal the skin. Joan, however, has observed patients die faster when bone is crammed inward, trapping dirt. She quietly starts leaving wounds open to drain, packing them with honey and linen, loosely covering with pig bladder membranes. This contravenes doctrine, but doubles survival rates. Centuries later, antiseptic pioneer Joseph Lister will formalize that principle. Clean wound, avoid sepsis. Joan reaches it through ruthless observation. And what about joints the quacks couldn't fix? Enter the traveling bone sowers. Yes, that's a job title. They roam fairs offering amputations for a flat fee, plus the sale of a souvenir peg leg carved on site. Without anesthesia, an amputation is a race against time. 90 seconds from first slice to tourniquet tie or shock kills the patient. To demonstrate skill and nerve, bone sowers sometimes perform a novelty act. A turnip is nailed to a plank next to the patient's limb. If the sawyer lops off the turnip first, crowd cheers, patient faints. Distraction plus reputation booster. Efficiency and entertainment bleed into each other, literally. Yet prosthetics evolve. A French metalworker named Ambroise Paré will craft hinged iron hands for wounded soldiers, proving function can follow fracture. But that's decades away. Here, Joan's clients settle for wooden crutches and prayer. Nevertheless, every mobility aid, whether a carved stick or a strapped peg, changes social norms. People see amputees hobbling to market instead of dying in bed, and slowly communities learn disability doesn't equal disappearance. Bone setters inadvertently spark early conversations about rehabilitation. Let's widen our lens again to China, 1590. Imperial Dr. Qi Ji Guang documents bone-setting schools where students practice on cadaver limbs soaked in vinegar to keep tissue pliable. They memorize 36 dislocation patterns, 18 fracture types, each with a named maneuver. Without global communication, these techniques parallel Joan's empiricism, proving human anatomy teaches the same lessons worldwide. Different languages, same screams. But wait, there's a thunderclap in our narrative. 1,600 ship surgeons spread New World discoveries, including crude cocaine extracts from coca leaves used by Andean healers. Word reaches Europe that chewing certain leaves kills pain in broken jaws. Pharmacists tinker, Jesuit missionaries send samples, yet the supply chain fails. And bones in Europe continue snapping, sans anesthetic for another 2 centuries. History teases relief like a candle glimpsed down a dungeon corridor, only to snuff it before you reach the door. Meanwhile, Joan ages. Arthritis nodules warp her own knuckles, ironic for someone nicknamed Snap Knuckles. She trains Kit, now a wiry teen with lightning reflexes and a penchant for scribbling observations. One evening after the fair, she confides in him. Pain's a thief, boy. It steals clean from the face first, then the heart. Our task ain't just to set bones, it's to buy the sufferer a moment where pain loses. Those words, Kit vows, will headline the preface of his future treatise, though he doesn't yet know how to spell treatise. Here's a hard truth medieval bone setters grasp instinctively. Time equals swelling. The longer a joint stays dislocated, the more tissue inflames, the harder reduction becomes, the worse the prognosis. So they adopt mobile practice. Joan travels township circuits weekly, carrying gear in a donkey cart, like an early EMS unit. We take ambulances for granted. They pioneered doorstep triage. Now cue the royal fracture I teased. In 1541, Henry VIII's daughter Mary, future Queen Mary I, slips on palace stairs, dislocating her shoulder. Court physicians recommend immobilization without reduction, fearing to touch a royal body. Weeks of agony later, the shoulder freezes. A sympathetic lady-in-waiting mentions a famed commoner bone setter. Mary, tough as rawhide, demands the woman be summoned. Whether it was Joan Tilney herself or another quack is lost to time, but records state a certain old mother manipulated the princess's arm until an audible clunk echoed. Mary's relief is immediate. Within months, she's riding again. The incident shocks court physicians into acknowledging manual reduction, and a royal proclamation soon licenses select bone setters, provided they pass a public demonstration before surgeons. Imagine the tension. Illiterate artisans proving skill before bearded scholars. Some pass, some don't, but the gate cracks open. The first timid handshake between folk practice and institutional medicine. Our narrative momentum is building. You can feel anesthesia rumbling on history's horizon. But before we get there, we'll wander through Georgian drawing rooms where fashionable ladies snap ankles learning the quadrille, and naval surgeons conquer compound fractures on rolling decks with rum for anesthetic and salt pork for dressings. We'll watch Napoleon's doctor pioneer field triage, deciding who gets saved and who gets morphine to die quietly. Each era resets bones and ethics in tandem. For now, close your eyes and hear the marketplace wind down. Torches sputter, shutters slam, and Mistress Joan packs her tools, joints creaking in sympathy with those she's mended all day. She counts coins, some copper, some silver, one precious gold angel pressed into her palm by a grateful noble whose valet she saved from amputation. She is the hinge between misery and momentum. Tomorrow she'll start again, because bones don't wait for paydays. Take a stretch, gently. Feel every tibia and ulna doing their job, and whisper thanks to the unsung hands that refined orthopedic arts through centuries of screams. Drop me a comment. Would you have braved Joan's stall or risked a crooked limb? Share this video with that friend who claims they'd have thrived in the simpler past. Let them savor Tudor traction chairs. Shuffle the pillow until it feels like a battlefield knoll beneath your cheek, because the torches of Tudor fairs have guttered out and we're plunging straight into the sulfur-stinking smoke of the 18th century. Before the cannon belches again, smash that like button the way an artillery crew slams home a charge. Click subscribe so you don't miss the next volley of gruesome history, and fire a comment telling me which bone you'd least like to see dangling in the breeze. I'm reading every grim confession while polishing a phantom bayonet. Ready? The drums are rolling, the surgeon's tent flaps open, and the scalpel is gleaming in lamplight thick with rum breath. Picture dawn on the fields outside Badajoz, 1812. A low mist hugs the grass, smelling of trampled barley and burnt powder. All night Wellington's redcoats clawed over the breach. Now the sun exposes the price. A carpet of men, some groaning, some still, a few shrieking with that high animal note that means bones been split and nerves are screaming pure Morse code to the brain. We glide past shattered gabions to the rear, where a canvas awning the size of a tavern has been christened the Butcher's Theater. 2 lanterns sway from tent poles, painting everything the color of old brandy. Beneath them stands Surgeon Major Elias Broom, sleeves rolled, apron so blood-stiff it could stand by itself. His hair is powdered white, not with fashion's flower, but with the settled ash of exploded grenades. Broom is no village bone-setter. He's Oxford-trained, carries a silver lancet case, and has dissected cadavers by candlelight. Yet he will rely on instinct every bit as feral as Mistress Jones when minutes count. His mantra, speed is mercy. Amputation in 90 seconds or shock swallows the man whole. No ether, no chloroform. Those miracles won't waft in until the 1840s. For now, the only anesthetic is rum, bite sticks, and the drummer boy's fife piping a song that's half lullaby, half dirge. The first casualty dragged inside is a lieutenant whose tibia is snapped in 2 jagged shards poking through crimson breeches. Compound fracture plus black powdered dirt equals infection waiting to happen. Broom sizes it up with a glance. Not a clean set. The bones splintered like ship timber after broadside. He could try a field reduction and hope for survival past sepsis, but gangrene loves shattered shafts. He opts for the saw. 2 orderlies grip the patient. A third pours rum between clenched teeth until it spills down the neck. The lieutenant locks eyes with the canvas roof and mutters a prayer older than empire. Broom tightens a leather tourniquet above the knee, palpating for femoral pulse, then takes his amputation knife, a long thin blade curved like a falcon's beak. One sweeping cut circles the flesh, skin first, muscle next, exposing glistening white bone in a single red curtain. 70 heartbeats left before shock deepens. He lifts the bone saw, teeth bright as moonlit rails, and saws with a rhythm carpenters would admire. Forward, back, forward. 5 strokes, and the leg falls into an orderly's waiting hands. They will toss it into the limb pit behind the tent, a trench buzzing with flies that haven't yet learned to salute. Now comes Broom's secret weapon, the cattling knife. He trims ragged fascia, draws down skin flaps to cover the stump, then threads a curved needle with waxed horsehair for 6 rapid sutures. 45 seconds remain. He powders the stump with wood ash, primitive antiseptic, slaps on a linen bandage dipped in vinegar, and shouts, "Next!" The lieutenant, pale but conscious, is hoisted away to the recovery row, where lavender oil burns in clay bowls to mask the odor of fear. Pause the gore a moment. Inhale slowly. That smell? It's heated pine pitch from the wagon outside, where a French prisoner, himself a carpenter, is boiling staves to craft makeshift crutches. War forges collaboration no treaty ever could. Soldiers missing limbs today will hobble on those crutches tomorrow, and their silhouettes will haunt every village they pass through, selling the story of bone setting without anesthesia better than any pamphlet. Let's swivel across the Atlantic to the deck of HMS Victory, Trafalgar, 1805. Cannonballs scream, masts shatter, and somewhere in the orlop, the ship's lowest deck, Assistant Surgeon Robert Rolfe crouches amid swabbing buckets and swaying lanterns. Salt water sloshes underfoot, mixing with blood into a brine that will preserve boot impressions until the planks are torn out decades later for souvenirs. Rolfe's challenge isn't cannonball amputations, though there are plenty, but closed fractures from falling rigging. Sailors tumble, ankles twist, arms snap, all while the ship pitches 40 degrees. Setting bones on solid ground is wrestling with pain. Doing it on a rolling sea is courting the gods. Rolfe improvises traction using belaying pins and block and tackle. A midshipman with a displaced humerus sits against a barrel while two deckhands haul gently on a rope tied to his wrist. Each roll of the hull threatens to jerk anatomy apart. So Rolfe waits until the deck steadies, feels the head of the humerus slip beneath his thumb, then pops it back into the glenoid with a click you can hear over the guns. Applause erupts. Sailors cheer anything that thwarts death. Rolfe straps the arm in a sling reeking of tar and hands the midshipman a wad of chewing tobacco. Nicotine to distract, saliva to spit in defiance at the French. Across Europe, the Enlightenment is rewriting textbooks, but bones are still set by feel, by sound of pop and grind, by taste of panic in the patient's breath. Yet intellectual currents seep even here. Broome carries a pocket copy of Percival Pott's Treatise on Fractures, first surgeon to identify that compound fractures kill via infection more than shock. Pott recommends immediate amputation for open fractures. Joan Tilney's descendant in Cheapside might disagree, preferring honey and patience. But Broome quotes Latin margin notes and the army follows. Let's step into a London coffee house, 1780. Candle glow flickers over pamphlets, quills, and pewter mugs. Two tall gentlemen debate the latest Royal Society paper describing mesmerism, animal magnetism, claiming to dull pain by passing hands over a body until trance sets in. A bone setter named Thomas Woolwich overhears, eyes glinting. Next day, at his St. Giles shop, he attempts mesmerism on a chimney sweep with a fractured radius. He waves fingers, mutters, the boy giggles, nothing happens, until Woolwich tightens a strip of cabbage leaf soaked in gin around the fracture site. Compression bandage plus placebo relaxation works. Swelling shrinks by evening. Woolwich, sensing marketing gold, advertises magnetic bone alignment, half-price Mondays. Engagement tactics existed long before YouTube. And what of the civilians back home? In Georgian drawing rooms, high-heeled slippers cause ankle sprains during minuets. Enter the dandy bone setter, Jonathan Gentle Hands Caro, who wears powdered wig and lavender gloves to reassure high society ladies. He swears by friction massage, kneading swollen joints with warmed almond oil laced with laudanum. The narcotic absorbs through skin, microdoses, enough to blur pain and win loyalty. Patients sigh, fans flutter, and Caro's appointment ledger fattens. He, too, preaches speed. Reduce within hours, or fashionable edema sets fashion back a season. Pain management inches forward. Physicians in Edinburgh extract opium alkaloids, producing tinctures standardized by Dropper. But dropper accuracy is dicey. Doses fluctuate between heavenly and lethal. Surgeons administer 14 drops for courage, then drag a saw across flesh. Sometimes patients sing patriotic songs mid-amputation. Sometimes they ascend into respiratory arrest before the saw touches bone. Trial and error with human souls for stakes. Let's join the Irish Rebellion of 1798. Field hospitals are barns with flapping doors. Sister Sorcha Nibronon, a Benedictine nun and clandestine rebel sympathizer, sets fractures between prayers. She employs bog moss packed with sphagnum, nature's own antiseptic. Recent lab studies confirm its phenolic compounds inhibit staphylococcus. Sorcha doesn't know Latin names, but she sees wounds stay pink rather than black. She also teaches recitation analgesia. Patients recite psalms in Gaelic. Rhythm steadies pulse, fosters communal resilience. Her methods will echo in World War I dressing stations as talk therapy. Shift south to Naples, where Vesuvius glows like a divine red-hot branding iron. Street urchins work perilous scaffolds harvesting sulfur. Broken bones are nightly currency. Local Osaiolo healers favor immobilizing limbs with strips of fresh cheese curd. Casein hardens into a brace, smells awful, works decently. They top it with lemon rind poultice. The citric acid discourages maggots. The Mediterranean breeze carries these citrus casein casts to French surgeons in the Peninsular War, who adapt the concept using plaster of Paris mixed with vinegar. You're witnessing the birth of the modern cast, minus the cheery neon Sharpie signatures. The hinge between folk craft and academic science creaks open wider when John Hunter, royal surgeon, insists on comparative anatomy. He dissects deer legs, horse cannon bones, even elephant femurs from menagerie casualties, mapping fracture angles to weight distribution. Hunter's lectures pack London theaters. Bone setters sneak in disguised as porters, scribbling notes. They'll later perfect calf bone splints shaped after Hunter's anatomical plates. Knowledge cross-pollinates like bees drunk on battlefield clover. But the greatest catalyst is war's brutal laboratory. At Austerlitz, Napoleon observes his surgeon Dominique Jean Larrey loading the wounded into horse-drawn wagons equipped with stretchers. Ambulances volantes, flying ambulances. Larrey's creed: treat within hours, not days. He organizes triage, hopeless cases given morphine-soaked sponges to bite. Survivables routed to makeshift theaters. Larrey limits menu to rapid amputations and decisive bone reductions, no dithering. Casualty survival jumps. Civilian medicine steals the blueprint after the wars, and train ambulances appear by 1850. Meanwhile, pain relief stands on anesthesia's threshold. In 1799, Sir Humphrey Davy inhales nitrous oxide, giggles, notices toothache vanishes. He scribbles, "The gas might be used for surgical operations." Medical establishment yawns. 2 decades later, American dentist Horace Wells will prove it. But for now, bones keep cracking under full conscious clarity. Return to Surgeon Major Broom's tent one midnight. He's experimenting.
A Spanish apothecary traded him a vial of tincture of valerian and monkshood, aconite. Broom soaks lint in the mixture, applies it to a cavalryman's shattered ulna. Within minutes, the man slurs his speech, pupils pin. Aconite is a cardiotoxin. Broom yanks the pad away, heart pounding. The patient vomits, then passes out. Muscle relaxation allows Broom to set the bone quietly. When he wakes, the soldier remembers nothing but dreams of waterfalls. Broom jots notes in a leather diary. Local stupor achieved, risk unacceptable. Even failures pave the path toward safe anesthesia. Let's examine instruments again. The petite screw tourniquet, invented 1718. A metal loop tightened by screw, giving surgeons bloodless feels and precious minutes. The hay saw introduces finer teeth for neater bone edges, smoother stumps, fewer necrotic flaps. Surgeons begin comparing outcomes, rudimentary statistics. One study counts 48 above-knee amputations. 30 die, 18 live. They conclude thigh stump survival benefits from midshaft cuts rather than hip proximal chops. Evidence-based surgery is stirring, like yeast in soldier's bread. The century's civilian disasters also advance orthopedics. The 1783 Calton Weavers' riot near Glasgow, musket volleys break limbs. Local doctor James Hill documents each fracture pattern, tries tight bandaging versus loose, concluding moderate compression prevents compartment syndrome, though he calls it flesh binding beyond nature. His pamphlet travels with peddlers, influencing practice from Yorkshire farms to Caribbean plantations. Speaking of plantations, enslaved Africans in the Americas developed bone setting, hybridized from West African, indigenous, and European methods. They craft splints from cane, bind with cotton, use pepper leaf poultices rich in capsaicin, a natural analgesic. White overseers sometimes drag cracked-ribbed comrades to these clandestine healers when plantation doctors fail. Medical apartheid momentarily bends. Skill outweighs skin when agony rules. Pain, always pain. A French salon rumor claims that focusing a small mirror on the fracture site channels solar anesthesia. Quacks sell gilded mirrors. Patients blister skin instead of numbing bones. But the placebo effect is real. Some swear by it. Even misguided attempts reveal pain's psychological leash. Let's ride a postal coach to Bath, 1795. There, in the pump room, genteel invalids soak in mineral pools to heal curved spines. Among them, a daring physician, Percival Heberden, invents the spring splint, a whalebone rod strapped along forearm fractures, its elasticity maintaining slight pressure as swelling ebbs. Patients can flex fingers, improving circulation, reducing stiffness. The concept of functional bracing is born. A village bone setter named Lydia Fenn purchases discarded corset stays, crafts her own version for local coal miners. Her splints outperform rigid boards, and soon Welsh valleys buzz with talk of Fenn's stays for broken arms. While Europe innovates, indigenous nations continue long-standing orthopedic mastery. The Cherokee set forearm fractures by suspending the arm between two river cane runners bound with deer sinew, then coating the whole frame in boiled pine resin. Lightweight, breathable, water-resistant, centuries ahead of plaster. When American surgeons encounter these methods during frontier wars, some take notes, smuggling ideas back east like contraband. At the close of our century, we stand on a cusp. Chemistry has isolated morphine, 1804, and ether sits in college laboratories waiting for dental showmen. Bone setters, folk and formal, sense change in the wind. Yet tonight, on the blood-slick boards of countless field tents, bones still crunch to the rhythm of saw teeth and mortal prayers. Surgeon Major Broom extinguishes his lantern, hands trembling not from gore but from triumphs measured in saved limbs. He wonders if, in some future age, a pill or gas will let him slice without screams. He cannot imagine MRI machines or titanium plates, but he hopes for silence.
Scoot a little deeper into the mattress trench. Let the blanket muffle the street lamp glare like thick London fog. And keep one ear cocked for the clatter of iron wheels. Because tonight we're rattling straight into the soot-choked marrow of the 19th century bone mill. But before the first steam whistle shrieks, smash that like button harder than a piston rod. Jab subscribe so you won't miss the clang of the next carriage. And drop a comment telling me whether you'd trust a Victorian factory surgeon with your kneecap. I'm sipping treacle-thick tea and reading every note while the city's gas lights flicker like tired stars. Right, draw breath through coal-tinged air, because the doors of St. Thomas's casualty ward are yawning wide, and the queue of broken bodies stretches all the way to the Thames. It's 1851, Great Exhibition year, and London is humming like a gigantic clockwork engine. Crystal Palace dazzles polite society with fountains and telescopes. But a mile east, along the Southwark riverside, men spill from textile mills, mangled by the very machines that promise progress. Our vantage point hovers above a cobbled alley slicked with grease. A messenger bursts through the crowd, bearing a blackened arm that bends where no joint exists. Compound fracture of the humerus, bone spike jutting like ivory splinter, muscle ribbons fluttering. He's one of Brunel's tunnel navvies, crushed by a misfired hydraulic ram. Inside casualty, the smell hits first. Boiled linseed oil from splints, chlorinated lime for half-hearted cleanliness, and a top note of stale blood. Ether has made its London debut, yes, but supplies are fickle, and lecturers argue about explosions. Chloroform is rising too. James Young Simpson went theatrical with his Edinburgh soirees just 4 years prior, but staff here ration every dram. Most cases still go en naturel, biting on leather straps, while surgeons singe nerve endings with red-hot irons. At the center of this chaos stands Assistant House Surgeon Joseph Lister, 24, hair slicked, eyes already tuned to infection's whisper, though carbolic acid is still a decade in his future. He examines the navvy's arm. Fractures filthy, artery nicked, pulse thready. In a shining private hospital, they'd knock the fellow out with a perfumed rag and cut clean. Here, there's no time. Lister orders 2 porters to hold the patient upright against a post like a bull at the abattoir. The man curses in Welsh. Lister apologizes in Scots, then pulls. Traction, Victorian style, isn't a delicate seesaw of calibrated weights. It's muscle against muscle. A medical student braces the shoulder. Lister hauls on the wrist until the bone ends scrape back into alignment with a sound like a cart axle seating. Blood sheets down Lister's apron. The navvy's roar rattles window panes. Without pause, Lister slaps a wad of lint soaked in turpentine onto the wound. Antiseptic? Hardly. It's to cauterize and frighten bacteria with sheer cruelty. He then wraps the limb in splints carved from willow and bandages so tight the fingers blanch. That's orthodox medicine. But down the road in Limehouse, another crowd forms outside a narrow storefront where a painted sign reads, Mrs. Abernathy, Anglo-Irish Bone Setter.
No diploma, no hospital affiliation, but scars run deeper than paperwork. Inside, the walls are hung with canes, crooked crutches left behind by former patients like votive offerings. A lamplight paints her spectacles gold as she inspects a dock worker's ankle displaced by a misstep on wet planks. She grips the foot, twists gently, and you hear a click, soft as a lark shot. Pain, yes, but not the primal scream from casualty. Her secret? Warmed goose fat rubbed along tendons and a whispered Irish lullaby that lowers the man's pulse before she moves. Placebo? Maybe. Yet her outcomes compete with St. Thomas's, and sailors swear by her blessed hands.
This friction between learned surgery and folk craft defines Victorian orthopedics. University men publish thick tomes. Alleyway healers chalk new notches on doorways. They often cross-pollinate in the most unlikely venues. Consider the Lambeth Bone Setters Guild, half mythical, meeting at the Dog and Duck Tavern. Surgeons in disguise buy rounds for rough-spoken healers, trading drafts of brown ale for tips on coaxing dislocations back without saws. In smoky corners, you can spot Lister's classmates scribbling notes on Abernethy's gentle reversal next to Latin phrases. Factory life accelerates demand. By 1860, Manchester spindles spin 24 hours and children feed looms. One slip and fingers shatter like china. Mill owners hire in-house medical men called limb sets, whose only tools are wooden spoons for leverage and strips of denim for traction. They work between humming belts, timing reductions to the rhythm of flywheels. No anesthesia. Stopping the loom for 15 minutes costs more than screams. Across the Channel, Paris hosts Baron Guillaume Dupuytren, Napoleon's former field surgeon, now the peacock of Hôtel Dieu. He champions resection of badly set fractures. Reopen the limb months later, saw away callus, realign, pin with ivory pegs. He uses chloroform when he can get it, but many poorer patients can't pay for the vapor. So he invents distraction. He hums opera to drown groans, calls it musical anodyne. He even times cuts to crescendo in Rossini arias. Students gape, scribble, imitate. Music therapy enters surgical folklore, though the patients still collapse in shock. Sail 3,000 miles west and land in Richmond, Virginia, 1862. The American Civil War is a meat grinder, eclipsing even Napoleonic carnage. At Chimborazo Hospital, largest on Earth, Dr. James Bolton oversees 5,000 beds, each a potential lesson in bone trauma. Chloroform is scarce as coffee. Confederate blockade runners risk their lives for barrels, but the front drinks it faster than it arrives. So Bolton turns again to speed. Here, bone setting divides into two camps: conservative surgeons and heroic. Conservative surgeons strap fractured femurs into Buck's extension, a scheme of weights dangling from the footboard, pulling bones straight over weeks. Heroic surgeons yank, set, and if fragments don't align, they amputate above the knee. Statistics begin appearing in Harper's Weekly. Survival rates 50% higher when limb is saved, but septicemia still stalks the wards like a gray ghost. Newspapers spin it, families panic, and suddenly bone setting is front-page propaganda. North and South tout whichever method seems most humane this week. Enter Hugh Owen Thomas of Liverpool, lanky, sharp-nosed, forever smelling of carbolized pitch. Born to a dynasty of Welsh bone setters, he apprentices under his uncle, then shocks polite medicine by publishing a treatise on the nature and treatment of fractures in 1860. No degree, just unstoppable evidence. Thomas preaches immobilization by Thomas splint, a wrought iron oval frame supporting thigh and shin, pressure relieved at the break site. He shuns anesthesia for reduction, fears hypoxia from chloroform. But once alignment is achieved, his splint lets patients lie pain-free, sometimes stand with crutches within a fortnight. He sends designs to Crimea, to India, to American battlefields. Decades later, the same splint will slash mortality in World War I, but for now, London surgeons scoff while secretly copying the blueprint. All this science churns within a city where public entertainment still features bone setting as street spectacle. Take Mr. Joshua Joint Jack Eddingshall, who performs in Whitechapel markets. He invites volunteers with stiff wrists onto a makeshift stage, then with a flourish snaps their carpal bones loudly back into place. Often they were never dislocated. He's mastered the art of cracking joints for applause. Yet occasionally a real dislocation appears, and Joint Jack sets it flawlessly, charging a tuppence pledge to Her Majesty's packet of miracle dust, which turns out to be brick powder. Crowds cheer, surgeons grumble, but medical students linger, fascinated by his tactile grace. Meanwhile, the countryside holds to older rites. Northumberland shepherds fix broken legs in sheep and humans alike using wands, branches split lengthwise, inner bark facing skin, bound with wool soaked in mutton fat. They swear bones knit faster amid lanolin. In coastal Cornwall, fishermen employ kelp ash mixed with egg white painted onto linen as a primitive cast. The iodine stings, doubling as antiseptic. Word of these practices filters back to metropolitan hospitals through railway porters, and curious registrars test kelp on gangrenous stumps, noting slower putrefaction. Victorians also flirt with electricity. After Faraday's demonstrations, charlatans peddle galvanic belts claiming to stitch bones with lightning. In 1870 Birmingham, Dr. Erasmus Potter rigs electrodes to a fresh ulna fracture, passing mild current for half an hour. The patient reports tingling but less pain. Potter publishes a pamphlet speculating current stimulates osteoblasts. The Lancet derides him, yet a century later, electric bone growth stimulators become mainstream. Visionaries and quacks often share the same top hat. Pain relief is evolving too. Hypodermic syringes arrived from France in the 1850s. Morphine injections spread across battlefields. Yet bone setting often occurs before morphine can be drawn. A railway porter with a splayed ankle is whisked into the station surgeon's closet. There's no time to sterilize a needle. Instead, the doctor offers a cigar laced with Indian hemp, ganja, imported from colonial shipments. The porter's pupils dilate, lungs relax, and the joint slides home smoother than rails at Swindon. Cannabis analgesia becomes railway lore until an 1868 temperance bill outlaws inebriating fumes on duty. Let's eavesdrop on an osteoclast of social rank. Lady Octavia Cortland, equestrian daredevil. 1872, she's thrown during a fox hunt. Tibia fracture, piercing riding habit. Her physician arrives in a dog cart with chloroform decanter, but Octavia waves it off. Fear of scandalous unconsciousness among grooms. She demands conscious reduction. The doctor, mortified yet obedient, applies Thomas's traction pulley, while two maids steady their mistress. Octavia grips a stick of willow bark, natural salicylate, aspirin's ancestor, and recites Virgil until bones click. Newspapers romanticize her stoicism. Sales of willow bark tonic spike among upper-class ladies, though none can match Octavia's grit. urban hospitals finally embrace antisepsis in the late 1860s after Lister's carbolic spray reduces post-op infections at Glasgow Royal Infirmary. Yet bone setting's front line, factories, mines, battlefields, lags. Many practitioners mistrust carbolic's caustic burn. In Welsh slate quarries, surgeon Evan Rees prefers honey and whiskey for antisepsis. He quotes scripture about land flowing with honey while aligning shattered femurs under lantern glow. Amazingly, his sepsis rate rivals Glasgow's thanks to clover honey's hydrogen peroxide trickle. Evidence builds, but establishment blindness is stubborn as cast iron girders. America now surges ahead with metallic fixation. In 1875, in Philadelphia, Dr. Frank Hamilton drills holes in a tibia and passes silver wire through, creating the first internal fixation. He uses ether. Patient snores. Yet the wires corrode. 2 months later, surgeon must reopen the leg without anesthesia because supplies are empty after a cholera outbreak. The man survives, carrying silver tarnished tattoos beneath skin, a walking billboard for both progress and its price. As bicycles conquer city streets, new fracture patterns emerge. Rider's wrist, a distal radius break from bracing during spill, and penny farthing ankle, where the massive front wheel crushes fibulas. Clinics publish guides. Some riders strap leather cuffs with integrated splints to prevent shatter, a fashion precursor to modern sports guards. Let's board the Orient Express, 1889. In the opulent dining car, a Russian count trips on Persian carpet. Ulna dislocates. A Persian bone setter named Bijan, traveling steerage, hears the commotion, offers aid. He uses scarf traction and a technique he learned in Isfahan Bazaar. Gentle vibration along the forearm triggers muscle relax, easing reduction. European physicians watching begrudgingly applaud. Days later in Paris, they attempt vibratory reduction on clinic patients, publishing mixed results but lauding Bijan's oriental delicacy. Medicine globalizes at 40 miles an hour. Pain science keeps pace. In Vienna, Karl Koller discovers cocaine's numbing power for eye surgery. Within months, adventurous bone setters smear cocaine paste on ankles before manipulation. Efficacy? Stunning. Addiction risk? Equally. London newspapers run editorials on coke crooked bones, while underworld apothecaries thrive. The century nears its curtain, and hospitals are finally stockpiling chloroform bottles engraved with skull and crossbones. Yet in Britain's colonies, Zulu battlefields, tea plantations of Assam, anesthesia is still luxury. Field medics rely on Indian hemp extract, cloves, and sometimes plain hypnosis. Surgeon Colonel Thomas Gallagher in Natal allegedly snaps tibia straight while murmuring repetitive chants that lull warriors into trance. Skeptics scoff until Gallagher's casualty lists show fewer shock deaths than colleagues using partial chloroform. Which leads us to the unsung hero of late Victorian trauma, distraction and story. Across workhouses, Salvation Army nurses tell wounded children tales of brave nights while aligning green stick fractures, timing pressure with climactic moments so pain blends with narrative surge. Neuroscience will one day confirm that focused attention modulates nociceptive pathways, but these women grasp it by heart. We leave the century as X-rays burst onto the scene. Röntgen's 1895 ghost images revealing misaligned bones beneath flesh. Within weeks, London surgeons compare intra-op reductions to X-ray plates, gasping at mistakes. Now bone setting becomes visible, mistakes unforgivable, standards inevitable. But anesthesia? Still unreliable, still absent in coal pits, cotton mills, rural infirmaries. The journey you've ridden tonight shows progress sprinting while pain limps alongside. Lean back, let the screen's blue glow dim to a moon sliver, and pull the quilt up until only the tip of your nose peeks out. Because we're slipping from horsehair splints into the smoke and chrome century when bones met bullets, cars, and X-ray ghosts. Before the ambulance bell rings, smash that like button the way a med student smashes a tibial mallet. Hammer the subscribe icon so these midnight ward rounds keep rolling, and tap the comments with the worst injury you ever walked off. I'm there between replies, lacing ether masks over paragraphs. Now exhale the city static and step with me through the iron doors of the Royal London Hospital. 1910, dawn shift, coal stoves roaring like dragons in the basement. Steel-rimmed spectacles fog as we enter casualty. Across tiled walls, electric sconces buzz. Edison lamps replaced oil just last decade, but the smell, disinfectant wrestling sweat, hasn't changed since Lister. Orderlies wheel in our first case, a 12-year-old messenger boy hit by a motor car cracking 20 miles an hour. Modern speed, medieval consequence. Right femur snapped mid-shaft, boot twisted backward so the heel kisses the shin. Anesthetists do exist, bright young doctors with glass syringes of morphine scopolamine or bottles of nitrous oxide hissing like carnival balloons. Only problem, supply chains. This morning, the hospital's nitrous tank sits empty after a weekend of dental clinics, and morphine is rationed thanks to new misuse of drugs whispers. So Surgeon Frederick Treves, yes, famed custodian of the Elephant Man, decides old school, reduction on conscious patient. He nods to Sister Havers, a granite-spined matron whose bedside manner could rivet ship plates. She pins the boy's shoulders. Two porters grab ankle and thigh, pulling opposite directions until muscle spasms surrender. Treves palpates through trousers, searching for alignment. He murmurs cricket scores, psychological ether, then feels the grating stop. Snap it back success. While sweat beads on the boy's brow, Trev slides on the newest marvel. A Thomas splint lined with sterilized wool, sides tightened by wingnuts. This, remember, was fringe tech 30 years prior. Now standard issue, accepted the way we accept traffic lights. Progress hides in plain sight, yet pain still howls in hallways. Outside hospital walls, Edwardian London bristles with motor perils. Taxi fleets bloom. Street surgeons call collisions bone shaker specials. Insurance companies commission studies. Femoral fractures up 60% since 1905. Radius breaks double in bicyclists dodging taxis. Engineers respond with safety glass, but orthopedists adapt faster, designing the first road splints made from aluminum, lighter for field medics to carry on motorbikes. Those medics? Often women from the newly minted Voluntary Aid Detachment, practicing traction on burlap mannequins while suffragette rallies echo nearby. They learn two key truths: keep tools simple and speak soft enough to drown screams. Hop continents. Chicago Stockyards, 1911. Assembly lines inspired by Henry Ford carve carcasses with ruthless rhythm. Packers dangle from hooks, and if a hand slips, cleaver meets metacarpal. Company physicians operate in corrugated iron sheds, nicknamed blade barns. Ether here? Rare. The remedy, icy brine sluiced over wounds to numb. Then bone set fast with pine splints soaked in shellac that dries rock hard under heat lamps. Workers swallow dope tea, Opium steeped with chicory to endure. Management loves it. Men return to belts within days. Addiction be damned. Investigative journalist Upton Sinclair scribbles notes, his future novel, The Jungle, already simmering. While factories maim, laboratories sparkle. 1912 Vienna, surgeon Lawrence Bowler watches X-ray plates like tarot cards. Wilhelm Röntgen's discovery now guides every reduction, revealing hidden angulations before plaster dries. Bowler drafts 3 golden rules: anatomical alignment, stable fixation, early movement. He champions traction beds with calibrated weights hung from pulleys, patients reclining like marionettes. In his wards, morphine flows. They aren't destitute navvies, but occasionally supply fails. Then he deploys Bowler's Whisper, a monotone lull that slows breath to 6 per minute. Primitive mindfulness decades before the word exists. Skeptics snort, numbers speak. Union rates soar, amputations plummet. Whistle, Europe shudders into war, 1914. Trenches chew men into puzzles of bone and mud. Field stations near Ypres are flooded, so medics improvise splint materials, rifle cleaning rods, entrenching tools, even baguettes hardened in shell explosions. Anesthetic shortages bite again. Chloroform casks sink with torpedoed ships. Ether evaporates en route over Alps. Enter Captain Robert Jones, Welsh orthopedic wizard, nephew of Hugh Owen Thomas. He standardizes the Thomas splint for battlefield, teaching stretcher bearers in 5-minute drills. Result? Mortality from compound femur fractures drops from 80% to 20%. Pain present? Absolutely. But men reach base hospitals alive, where ether waits. Sometimes not. Verdun, 1916. French medic Marie-Louise Servier runs a forward aid post nicknamed Rabbit Warren. Shell fire constant. No anesthetic. She mixes cognac with powdered quinine, sloshes it down throats, then realigns ankles by lantern, singing Breton sea shanties. Soldiers later say the songs numbed them better than drink. Neuroscience will call it conditioned analgesia. Legends call it mercy. Across the Atlantic, America wades in, 1917, and with it, the Surgeon General's office issues Manual of Splints and Appliances. Illustrated by artists fresh from medical school trenches, it becomes the Bible of reduction. Yet stateside factories still lag. In Pittsburgh steel mills, fractures set by bone wranglers using water-soaked newspaper bandages that dry to papier-mâché casts. Immigrant laborers accept agony in exchange for keeping limbs. Meanwhile, vaudeville theaters adapt. Contortionists teach medics joint-loosening techniques to ease dislocations. In return, they borrow anatomy phrases to spice posters. War ends, roaring 20s dawn. Jazz clubs strobe, flappers dance on sprained ankles nightly. Harlem's Harlem Hospital opens colored orthopedic ward under Dr. Lewis T. Wright, first black surgeon on staff. He trials intramedullary fixation, inserting ivory pegs down femoral canals. Painful insertion even with ether, but once rod sits, patients walk earlier. Word spreads through speakeasies. Bootleggers fracture legs outrunning cops, then bribe orderlies for Wright's quick sticks. Pain still attacks, yet progress strides. Let's swivel to Tokyo, 1923. Great Kanto earthquake topples neighborhoods, thousands trapped under beams. Japanese bone setters called sekotsushi rush in. Trained in judo's off-mat healing art, they relocate joints with sumi ink markings to memorize anatomical lines. Anesthesia non-existent amid rubble. They rely on shiatsu pressure behind earlobe, vagus nerve reflex that momentarily blurs consciousness. Victims later claim they floated outside bodies during reduction. Western missionaries witness pen papers on Oriental nerve pinch none can replicate. Back in Europe, automobiles breed new injuries: dashboard knee, steering wheel chest. Surgeons craft hinged plaster casts embedded with copper wires attached to Franklin batteries. Primitive electrostimulation aimed to speed callus. Patients describe buzzing warmth, distraction from throbs. Placebo or not, bone knitting seems quicker, but skin burns warn of limits. Pain relief leaps. 1925, German chemists synthesize pethidine. 1928, British company markets ethyl chloride spray, a topical freezing agent. In London's East End boxing gyms, trainers keep chilled vials ringside. A fractured finger gets blasted numb, snapped straight between rounds, taped, and match continues. Governing bodies frown, crowds roar. Yet rural clinics still mirror medieval huts. Appalachian Mountains, 1930s, granny women set bones with corncob splints dipped in beeswax. They recite psalms while relatives crank Victrola hymns, music as dulling blade. University anthropologists collect stories, confirm many recover fully, though malunions hide under long skirts. The Great Depression crushes hospital budgets. Surgeons improvise traction frames from bed slats, reuse plaster bandages, cut morphine doses. In New York, Dr. Helen Warden leads breadline clinics, teaching unemployed veterans to self-apply figure-8 bandages for clavicle fractures. Painful first days, but independence priceless. WPA photographers capture gaunt men with D-ring slings, stoic eyes, shaping visual memory of era. Scientific Beacon, 1935, Mayo Clinic's William Plaster, yes, real surname, introduces fiberglass impregnated with resin, lighter than plaster of Paris, sets within minutes. Drawback: exothermic heat scorches if water too warm. Early adopters scald patients' skin, prompting lawsuits. But once protocols refine, casts become Technicolor canvases for children's doodles. Cast signing, a new ritual easing pain with social ink. Anesthesia sees seismic shift. 1937, Danish anesthetist Harold Lund invents thiopental, intravenous marvel, knocking patients out in seconds. Bone setting enters era of silence, at least in wealthy hospitals. Yet Spanish Civil War erupts same year. On dusty Aragon fronts, ether again scarce. American volunteer medic Norman Bethune introduces mobile blood transfusion vans, but for reductions he still wields raw force. He documents technique: 2 helpers, leather strap between teeth, swift traction, splint, morphine if captured from enemy stores. Pain persists, overshadowed by bombs. Second World War explodes. Advances sprint. Nazi Germany deploys Elizarov's external fixators, circular frames with tension wires, on Eastern Front. Soviet surgeons refine, performing limb-lengthening experiments on frostbitten soldiers. They administer vodka shots before wire insertion, then distract bone 1 millimeter per day. Agony monumental, yet some amputations averted. Torture? Miracle? Lines blur like tracer rounds. Western allies pioneer penicillin, slashing infection. Pentothal saturates operating tents. Still, when Arnhem paratroopers fracture ankles behind lines, Dutch resistance bone setters work without drugs, stuffing socks with local poppy seeds for crude paste analgesic. Some troopers later keep seeds as souvenirs, testament to pain survived. War spawns aviation medicine, pilots ejecting, break vertebrae,
Spinal boards devised. Australian flying doctors adapt for outback. Morphine drops via mail plane scarce, so they rely on jackaroo traction, using saddle cinches, gum tree branches. Patients grit teeth against bush ballads strummed on battered guitars. Post-war prosperity ushers orthopedic renaissance. 1950s, Davos, Switzerland. AO Foundation forms, preaching rigid internal fixation with stainless steel plates and screws. Workshops echo with drills. Anesthesia reliable now, halothane and cyclopropane. Yet cost high. Developing nations still practice old ways. In rural India, bone setters known as traditional osteopaths manipulate fractures under mustard oil massage, then immobilize with bamboo splints tied by torn saris. Government launches training schemes, merging folk skill with X-ray vans. Transition aches but saves limbs. Pain science rebounds. Gait control theory, Melzack and Wall, 1965, explains why rubbing a bruised shin dulls pain. Nerves compete like telegraph lines. Hospitals incorporate TENS units, pads delivering mild current, echo of Birmingham's galvanic belts half a century prior. Meanwhile, hippies rediscover cannabis. San Francisco clinics trial THC pills for post-reduction pain. The circle closes. Slide your phone onto night mode. Let that soft amber halo spill across the sheets and scoot one click closer to the speaker, because tonight the fluorescent decades kick in, and with them a brand new catalog of fractures that look suspiciously like skateboards, moon landings, and disco balls tipped off their axis. Before we clock in, punch the like button the way an ER nurse punches morphine vials to break the seal. Jab subscribe so the algorithm keeps wheeling this gurney back to your feed. And in the comments, confess your wildest sports wipeout. Bonus points if there's still gravel under the skin. All set? Good. Feel that hush? That's the hush of a hospital corridor at 2 a.m. 1973, when the Coke machine hums like a beehive and every fluorescent tube flickers with the patience of a rattlesnake. We start in Southern California, Venice Beach, concrete playground of polyurethane wheels. Plastic revolutionized everything. Surfboards for pavement, yes, but also casts. Orthopedists at Santa Monica Hospital notice a spike in sidewalk surfer injuries. Callus fractures splintering wrists, navicular bones snapping like wishbones under the sudden torque of an ollie gone wrong. By 74, they coin a term, skateboarder's thumb. Then hurry to invent a brace light enough that teens will actually keep it on. Enter thermoplastic splints, thin white sheets heated with hair dryers, molded right on the palm, hard in minutes. Anesthetic? Sure, in theory. But paramedics on the beach rarely pack more than aspirin. So they adopt a surfer trick. Crushed ice in a waxed paper cup rubbed along the break until skin numbs, then splint on the spot. The pain hits later, back home, when Beach Boys fade and swelling blooms like jellyfish. By then, the cast's already signed in Sharpie. Spin east to Pittsburgh, 1976. Steel mills gasping their last breaths. Factory automation creates layoffs and, ironically, new injuries. Rookie maintenance men trapped in conveyor belts because robotics misfire. Dr. John Charnley's hip replacement techniques trickle down to limb salvage. Titanium intramedullary nails inserted through tiny incisions. Operating rooms glow with halogen. Anesthesia is now balanced. Thiopental induction, isoflurane maintenance. But urban hospitals can't afford enough anesthesiologists. Solution? Nurse anesthesiologists rise. They glide between ORs, titrating gases while surgeons drill metal. One nurse, Ruby Torres, hums Motown under her mask. Patients later swear they remember the chorus of "Ain't No Mountain High Enough" more clearly than the scalpel. Music therapy meets modern pharmacology. Pain dampens in stereo.
Across the Atlantic, the Troubles rage in Northern Ireland. 1978, Belfast. Street medics patch gunshot comminutions using defunct phone booth aluminum panels trimmed with tin snips. With curfews, ether deliveries stall. Local pubs provide Jameson, but surgeons prefer ketamine for field amputations. It preserves breathing and, oddly, induces vivid dreams of green hills far from barricades. Some wake mid-reduction giggling at leprechauns, then crash into sobs. Psychiatry begins charting emergence phenomena, but orthopedists scribble one note: less screaming, cleaner reduction.
Meanwhile, technology redefines seeing bones. 1979, CT scanners arrive. Radiologists compare it to stepping through a portal. Fractures viewable layer by layer like geological strata. For orthopedic planning, it's magic. For patients, another round of cold, dye-flavored nausea in a spinning tube. Yet CT doesn't dull pain. It simply predicts how much will be inflicted, resetting the mess. Surgeons at Massachusetts General publish a study. Precise imaging cuts average reduction force by 18%, meaning slightly quieter grunts from awake patients in resource-strapped wards. Speaking of strapped, welcome to Kathmandu, 1982. Backpacker traffic skyrockets. Everest dreams shatter ankles at Lukla airstrip. Helicopter evacuations cost thousands, so many hobble into Himalayan bone-setter tents, Gamchis, where saffron incense mingles with the copper tang of blood. No anesthesia above 10,000 feet. Oxygen cylinders are rationed for altitude sickness, not fractures. Gamchis paint fractures with arnica oil, chant mantras timed to exhalations, then yank bones like they're ringing monastery bells. Western climbers describe a paradox: agony so bright it eclipses fear, followed by lucidity as crisp as mountain air. Neuroscientists later label it endorphin storm, a free opiate rush courtesy of near-spiritual terror. Drop to Sydney, 1984, Olympic year for sports medicine. Australian Institute of Sport opens an injury clinic with plush budgets. They introduce patient-controlled analgesia pumps, plastic buttons tethered to morphine drips. But here's the twist. Elite athletes fear opiate side effects. They choose nerve blocks instead. Lidocaine syringes guided by portable ultrasound wands resembling electric shavers. Blocks last 2 hours. Casts applied in radio silence. No screaming. Surgeons almost bored. Yet once the block fades, night swells with throbbing boomerangs of pain. Athletes record diaries. Feels like a dingo gnawing my tibia. High-performance mindset meets primal hurt. Both parts of the podium. Back in the States, BMX fever grips small-town parking lots. 1985, Tulsa ER triages 8 collarbone breaks in one Saturday. Dr. Janet Sawyer tires of figure-8 braces slipping under sweaty jerseys. She patents Velcro clavicle harnesses, color codes them neon to match bikes. Compliance skyrockets. No anesthesia necessary for simple clavicle sets, just a numbing spray and quick scapular squeeze. Kids brag about harness colors like war medals. Zoom north to Toronto, 1986. Snowboarders, still banned at many resorts, sneak in after hours. One misjudged halfpipe, one spiral tib-fib fracture. Paramedics on snowmobiles carry Entonox, nitrous oxide plus oxygen, cylinders nicknamed laughing sleds.
Rider inhales, giggles at northern lights, while medic aligns shin with crunchy popcorn sound echoing across drifts. Entonox leaves bloodstream in minutes. By the time ambulance hits asphalt, laughter dims into aches, but bone stands true under vacuum splint. 1987 brings a quieter revolution: patient advocacy. Chronic pain veterans lobby Congress, claiming undertreatment is epidemic. Hospitals adopt 10-point pain scale, the smiley face chart taped to every bedside. Strange irony. For millennia, pain was inevitable. Now it's a fifth vital sign scribbled beside pulse. Still, in underfunded rural wards, the chart sits while lidocaine vials stay locked pending approval. Paper compassion, real throbbing. Let's leap to 1988 Seoul Olympics gymnastics finals. Soviet prodigy fractures ankle on vault in prelims. Team doctors slip her a cocktail. Diclofenac injection, tight elastic taping, mental rehearsal audio. She competes next day, sticks landing, collapses behind curtain. Post-games X-ray shows talus crushed. Surgeons in Moscow attempt new fixation screws made from bioabsorbable polymers. Less hardware removal later. During op, halothane flows, but supply glitch cuts line. They finish under half dose. Her screams echo through steel corridors. Gold medals often mask bone dust. Late 80s hip-hop births breakdancing injuries, hence break indeed. Newer community clinics see radial head fractures from windmills gone sideways. They can't afford fancy anesthetics. Instead, they crank boom boxes with bass heavy enough to rattle molars. Patients ride rhythm while physician Garrett Doc G. Reynolds snaps bones into place mid-beat. He swears syncopation distracts spinal gating pathways. Research? Zero. Street cred? Infinite. 1990s dawn with Gulf War. Desert combat means medevac helicopters with onboard ketamine kits. Field medics become anesthetists in Kevlar. Meanwhile, at home, mountain bikes crash down neon Colorado single tracks. Orthopedic surgeon Dr. Ed Burke pioneers functional bracing. Instead of full leg casts, hinged braces allow partial motion, reducing muscle atrophy. To set tib without OR, he injects lidocaine along periosteum, uses portable C-arm imaging, adjusts screws through skin, percutaneous plating. Patients watch on little monitors like sci-fi, wincing but fascinated. Pain plus tech merging into story they retell over craft beer. Trauma airlifts surge. 1992 Los Angeles riots, 20 fractures hourly. LAC-USC surgeons introduce damage control orthopedics. Quick external fixators delay definitive plating until patient stable. There's morphine, but chaos drains stores. Residents trade coffee for pharmacy keys. Some intubated patients still twitch when pins drive through tibias. Ventilators muffle their groans. Street outside burns. Inside, drilling continues. Pain overshadowed by sirens. Now cross-Pacific again. Rwanda, 1994. Genocide overwhelms Red Cross posts. South African volunteer Dr. Thandiwe Kube sets femurs with rebar rods scavenged from collapsed buildings, cut to length by machete sparks. No anesthesia except homebrewed banana beer. She teaches breathing techniques. Inhale 4 counts, hiss out 6, timed with each traction pull. Survivors later credit her voice cadence for survival. This is bone setting at civilization's cliff edge, proof that technique, not tech, determines fate when the pharmacy empties. Mid-90s bring snowboard halfpipe to Olympics. Injuries escalate. Orthopedists coin borders break. Spiral humerus from catching hedge. Gore-Tex casts debut. Waterproof, breathable, smells less like feet. Application still hurts. Saw removal, though, now burns neon sparks and squeals like DJ scratches. Kids film it for early YouTube. 1997. Space Shuttle Columbia hosts first ortho experiment, chicken bone fracture healing in microgravity. Findings hint weightlessness slows callus. Meanwhile, back on Earth, Russian cosmonaut falls during EVA training, dislocates shoulder. Mission timeline tight, they pop joint back using Kocher maneuver plus 5 milligrams intranasal fentanyl, flight version of mu opioid. Astronaut later notes stars looked sharper mid-reduction, pharmacologic lens flare. Turn of millennium. 2001, skateboarder Tony Hawk lands 900. Kids attempt, radius snaps nationwide. Hospitals adopt buddy casts with built-in shock sensors. They beep if teen tries to skate before bone sets. Spoiler, teens rip out batteries. Pain management enters new chapter. OxyContin marketed as near non-addictive. Orthopedists prescribe by handful, thinking benevolence. 5 years later, we tally overdose epidemics. Bones mend, but communities fracture. Parallel path in Sierra Leone. Civil war ends. Médecins Sans Frontières establish trauma center with single ultrasound for nerve blocks. They teach local techs to find femoral nerve using flashlight reflection on skin. Success drops opioid use significantly. Western journals publish. Wealthy hospitals buy $90,000 ultrasound towers forgetting flashlight method. 2004, Fallujah. IED blasts shred limbs. Combat medics carry fentanyl lollipops. Soldiers suck while tourniquets tighten. Rapid sequence, splint, morphine, Black Hawk. In flight, pain merges with rotor wash white noise. Stateside, Walter Reed pioneers mirror therapy for phantom limb pain. Brain rewires, but initial sessions cause migraines. Bone pain replaced by ghost aches. Back at home, parkour bursts across Paris rooftops, then YouTube. 2006, cat leap gone bad, bilateral calcaneus fractures, heels pulverized. Surgeons opt for minimally invasive plates inserted through 2-centimeter incisions to preserve blood supply. Patient on table receives spinal block, bupivacaine plus fentanyl. He's awake, watches ceiling tiles, hears screwdrivers clicking in bone. Like IKEA inside my feet. He later jokes about Allen key scars. By 2008, economic crash slashes hospital budgets. ERs overrun, propofol stocks dwindle, plus Michael Jackson headlines make insurers wary. Some departments revive ketamine for reductions, now celebrated for maintaining airway. Tiktaalik era cycle, old drug, new badge. Patients report psychedelic tunnels during shoulder relocations. Instagram not yet a thing, memories remain unfiltered. Soccer mania. 2010 South Africa World Cup. Vuvuzelas drown stadium, but not fractures. Ulna breaks from drunken falls. Field clinics use cold spray, ethyl chloride, then cloth espadrille splints, letting fans hobble back to seats before final whistle. Pain overshadowed by national pride and plastic horn tinnitus. That same year, Haiti earthquake pulverizes Port-au-Prince. Global surgeons deploy external fixators printed by 3D plastic printers flown in pieces. But anesthesia? Scarce. They hack spinal blocks using lidocaine toxicity charts scribbled on cardboard. Volunteers share one portable pulse oximeter. Red beep synchronizes with saw strokes. Pain still rampant. Volunteers trade granola bars for leftover ketamine from veterinary units. Horse tranquilizer becomes human mercy. 2012. GoPro cameras mount on wingsuits. Base jumpers flood Swiss valleys. Compound tib-fib fractures spike. Rescue helicopters carry chilled bags of TXA, tranexamic acid, to curb bleeding. For pain, intranasal ketorolac, non-opioid miracle. While medic aligns bones, Jumper films POV of his own reduction, later uploads with dubstep soundtrack. Pain becomes content. Tech leaps. 2014, Google Glass pilots heads-up orthopedics. Surgeons see CT overlay on limb while reducing. But in Kenya, solar-powered sterilizers matter more, letting rural clinics boil splints and scalpels. Community health workers use WhatsApp to send X-ray photos to Nairobi specialists. Advice returns via emojis. Death equals bad angulation. Wrench equals adjust screw. Patients bite leather straps. Global telemedicine shrinks distance but not discomfort. 2016, opioid crisis peaks. CDC issues guidelines. ERs limit scripts. Ultrasound-guided nerve blocks surge. A med student duo designs $80 3D printed nerve block trainer. YouTube tutorials explode. Patients now enjoy near-painless clavicle sets under single-shot interscalene blocks. But once lidocaine fades, NSAIDs and ice are the diet. Pain re-democratized. Same year, Syria's bombed Aleppo implants cave hospitals. Diesel fumes mix with betadine. Orthopedic Dr. Farah Al-Najjar improvises modular external fixators from plumbing joints. To sedate, she combines ketamine with Quran recitation via battered speaker. Children whisper ayahs while drift snow of plaster dust settles on shattered limbs. Photographers smuggle images out. Humanity's bones bared, yet unbowed. 2018, e-scooters invade cities. Scooter ankle enters trauma lexicon. Urgent care chains advertise same-day plaster, Parisian pink, Instagrammable casts to influencers. They offer VR headsets playing tropical beaches during reduction, distraction analgesia version 3.0. Survey shows headset cut perceived pain by 25%. Headphone sanitization remains unsolved. Pandemic 2020. Empty streets reduce traffic fractures, but home DIY injuries skyrocket. People attempt sourdough oven installations, drill through metacarpals. Hospitals overrun by COVID. Elective ortho postponed. Home set bones return. Telehealth sessions guide patients to align fingers live on webcam using kitchen spoons as splints. No anesthesia beyond Tylenol and sheer dread of going to ER. Some heal crooked, some perfect. A reminder that bone setting can retreat centuries overnight. 2021, mRNA vaccines free or schedules. Postponed joint replacements surge. Robot-assisted fracture plating becomes mainstream. Patients under general anesthesia chat with surgeons via Zoom pre-op, sign e-consents. Post-op pain bundles emphasize regional anesthesia, gabapentin, mindfulness apps, opioids last resort. Virtual reality again steps in. Cold blue northern lights swirl during first physioflexion. Gait control theory meets Oculus. And here we hover, present tense humming like hospital ventilators. Bones still break. Electric unicycle riders, climate protest rooftop falls, Mars simulation habitat accidents. Anesthesia now mixture of lidocaine, nerve blocks, augmented reality distractions. But there will always be corners of the map where traction still means ropes over tree branches, where chanting or guitar chords substitute for propofol. History loops, tech spirals upward, yet pain remains the constant heartbeat under every cast. Dim whatever lights are still brave enough to glow in your room. Press your earbuds in that extra millimeter and lay your hands palm up across the blankets. Feel the pulse in each metacarpal, the soft throb that proves every bone has its own metronome. Before we scrub in for the finale, crack the like button the way you'd crack a glow stick. Hit subscribe so future midnight surgeries find their way back to you. And in the comments, confess the one piece of body tech you'd volunteer to beta test. Printed vertebrae? Smart casts? Paint-off switch? Your passion fuels the algorithm stretcher that hauls these histories through the feed. Done? Cool. Let's wheel you down the hallway where tomorrow's orthopedics is already ticking beneath the linoleum, waiting for the next unlucky skateboarder or astronaut to trigger it.
The year is 2025, and the fracture garden now blooms with silicone. Walk into John Radcliffe Hospital, Oxford. A teenager who face-planted on a VR treadmill is getting a scan in a machine that looks more like a croissant-shaped pod than an X-ray gantry. It's called photon-counting CT. Instead of smearing the picture with generalized radiation, it reads individual photons, color-codes them by energy, and produces a 3D model so finely detailed you can zoom down to trabecular pores smaller than a grain of salt. Surgeons rotate this hologram in mid-air using hand gestures. Minority Report meets med school. Why does that matter to pain? Because precision means fewer pulls, digs, and resets. When you know exactly how a fracture line snakes, you can slip in microplates like a locksmith rather than smash bones into alignment blindfolded. But notice, the accuracy lives in a machine. The patient still awaits needles, saws, and that primal dread when the gown rustles against raw nerves.
Fast forward 6 months, same hospital, different wing, bioprinting lab. Here, stem cell gelatin sprays in micron-thin layers around a collagen scaffold like a high-resolution frosting robot. They aren't just printing cartilage, they're printing living, vascularized bone segments. A woman with a mandibular blast injury from a car battery explosion watches through glass as her future jaw condenses layer by layer, incubated in warm nutrient baths, pulsated with tiny mechanical vibrations to trick the cells into thinking they're inside a body that's chewing steak. When it's ready, surgeons will swap her shattered mandible for the printed one, connect artery cuffs like Lego ports, close the incision with barbed sutures that dissolve in months. Anesthesia? Yes, balanced, elegant, delivered by closed-loop AI pumps that read EEG microblips and auto-dose propofol in real time. Pain may finally become a variable solved by feedback control, like cabin temperature. But there's a hush of philosophic unease in the corridor. If pain disappears from bone setting, do we lose the primal respect that kept acrobats cautious? More on that moral fracture later.
Cross the Pacific to Kobe, Japan, 2026. Earthquake early warning buzzers cut through dawn. Commuters dive under desks. Steel beams groan. Casualties pour into robotics-equipped field tents staffed by disaster response exoskeletons. Human surgeons wearing powered frames that amplify their strength threefold. You see Dr. Naoko Sato lift a 120-kilo concrete slab off a trapped cyclist with one arm, the servo motors whining like summer cicadas. No fentanyl here. Nanoparticle local anesthetic delivered by skin patch the size of a postage stamp. It migrates through sweat pores, parking itself around nociceptors like microscopic bubble wrap. Victims retain motor control, yet report pain below a 2. Bones are reduced on folding tables with ultrasound probes nested in the forceps. The entire supply chain, power, meds, imaging, runs off solar blankets plus one hydrogen fuel cell. Old school plaster, replaced by carbon fiber mesh that sets under UV lamps in 20 seconds. By the time aftershocks fade, patients have tweeted selfies in their black mesh casts, hashtags in kanji, hashtag QuakeBones, hashtag still standing. But we promised you space, didn't we?
Buckle up for 2028, Gateway Station orbiting the Moon. A micrometeorite punctures the habitat's cupola. Astronaut engineer Malik Zhao ricochets into a bulkhead, fracturing his radius. Gravity is 1/6 of Earth's, which seems gentle until you realize it wrecks the biomechanics of reduction. Nothing stays put, traction is slippery, and floating bone fragments drift like confetti. The crew doctor spins a handheld bone printer. Think glue gun meets bioreactor, loaded with calcium phosphate paste that hardens when hit by a low-power laser. First, she aligns the fracture using balloon tourniquets that push bones together without heavy weights. Then she draws a filament of paste along the crack, laser cures it, and wraps the arm in a graphene sleeve laced with piezoelectrostatic fibers. Every time Malik flexes, the sleeve harvests vibration energy, powering microcurrents that stimulate osteoblast growth. Pain control? A nasal puff of subdissociative ketamine, fast, non-sedating, zero puke risk in micro-G where vomit is lethal. The world's first in-orbit fracture heals in 2/3 the Earth time. NASA revises the mission manual, adds a new chapter called Additive Osseous Repair. On TikTok, Ground Control uploads time-lapse of his X-ray like a blooming flower, captioned, "Space bones knit faster. Who knew?" Zoom back to Earth 2029. The opioid crisis is finally plateauing, but at tragic cost. Regulatory pendulums swung so far, doctors now fear prescribing codeine for a stubbed toe. Enter electroanalgesia wearables. Picture a wristwatch that fires targeted magnetic pulses into spinal cord gating circuits. Jane, a Milwaukee barista who shattered her distal ulna slipping on black ice, opts for the device over hydrocodone. Surgeons align her bone with percutaneous wires under mild lidocaine. Then they clip the watch to her upper arm. Whenever pain spikes past 6, she taps the bezel. Pulse trains distract dorsal horn neurons, dropping the burn to a mellow 3 without fuzzing her brain. She pours lattes 12 hours later, albeit one-handed. Starbucks employees worldwide petition for insurance coverage of Zap watches. Insurance actuaries scramble but realize it's cheaper than addiction rehabs. Same year in Nairobi, a startup called Bone Bank launches. They harvest discarded femoral heads from hip replacements, decellularize them, soak them in growth factors, and freeze-dry them into osteochips, shipped in pizza box-sized coolers by motorcycle couriers. Rural clinics can rehydrate a chip, sculpt it with scissors, and patch critical bone defects. No donor site morbidity, no immunosuppressants. Anesthesia remains spinal lidocaine plus storytelling. Elders recite Swahili folktales timed to surgical milestones. The patient drifts on cultural hypnosis. Pain is punctuated by laughter when trickster tales crescendo. Western observers call it narrative analgesia, but locals shrug. They've done it for centuries. Let's breach 2030. AI triage kiosks replace front desk clipboards. You stick your broken hand into a black box. LiDAR, thermal imaging, and machine vision algorithms spit out a fracture classification and a suggested reduction maneuver. The program warns, high pain expected. Would you like immersive VR distraction? Users choose from curated scenarios, surf pipeline, stroll Kyoto cherry blossoms, attend BTS reunion concert. Meanwhile, a nurse practitioner, guided by AR glasses overlaying reduction vectors, manipulates bones. In pilot studies, patients inside VR remember almost none of the procedure, just fragments of color and whooshing sound. On exit, they still need NSAIDs, but memory of specific agony is Swiss cheesed. Ethicists raise eyebrows. If we erase pain memory, do we risk PTSD mutation?
Do our bodies forget why to avoid danger? Debate roars in journals. YouTubers parody it. Next-gen bones, zero trauma. Try at home.
Next stop, Medellin, Colombia, where ex-cartel hideouts transform into biotech incubators. 2031 debut of osteoputty, a thixotropic gel seeded with CRISPR-edited stem cells that churn out bone at triple speed. Surgeons inject it into comminuted tibias, too shattered for screws. The gel stiffens when stress applied, softens when idle, constantly remodeling. But there's a catch. Cell lines occasionally overreact, producing exuberant callus that fuses joints. Early users nicknamed Stone Men. A fail-safe molecule, an ingestible shutdown key, is in development. But the cautionary headlines splash. When bones heal too well. Pain-wise, patients initially feel fiery pressure, then a curious itch as new bone sprouts. Scratching skin above fracture becomes national pastime. Clinics hand out satin mittens to curb infection.
By 2032, neurotech leaps again. Deep brain stimulators, once reserved for Parkinson's, now target the periaqueductal gray, central control switch for pain. Post-op, a skateboarder with compound radius fractures can dial pain from 9 to 2 with a smartphone slider. Surgeons worry he turns it down too low, skates with cast on day 3, hardware bends. Clinics implement usage locks. Pain can't drop below 4 first 3 weeks. Hackers post jailbreak tutorials. Lawsuits bloom like bruises. Your Honor, my app update crashed and the agony returned mid-lecture.
Population is aging. Fragility fractures soar. 90-year-old former florist in Copenhagen breaks hip. Instead of total replacement, she receives magneto-responsive bone beads, tiny spheres injected at break ends. External magnetic field oscillates, lining beads like pearls, bridging gap as scaffold. No OR, no intubation, just local anesthetic and Mozart playing. She walks with cane in 10 days, says it feels tingly like champagne bubbles in my thigh. Medicare equivalents drool over cost savings. Let's not ignore the dystopian flip side. 2033 War Zone, Baltics. Autonomous drones fire flechettes that shatter limbs but avoid lethal hits. Policy, maim, not kill. Field hospitals low on supplies deploy pain coins, crypto tokens redeemable for analgesics. Soldiers trade them like poker chips. Each ketamine dose costs 10 coins. Refusing med nets you 5 coins as bonus hazard pay. Economists studying incentive theory applaud. Ethicists scream. Pain becomes currency, bone setting a marketplace. Meanwhile, back in civilian sparkle, elite climbers free solo augmented cliffs. 2034, Yosemite's Dawn Wall 2.0 route includes embedded smart anchors scanning biometrics of climbers' finger bones in real time. If microfractures approach critical, anchor LEDs flash red. Still, one climber pushes, third phalanx snaps. Rescue drone arrives with 3D printed finger splint tailored from his last Instagram hand scan. It includes built-in cooling microchannels circulating menthol fluid, continuous cryotherapy without ice. He wraps down, live streams the encasement, fan donations spike. Pain management? Topical cannabinoid patch plus guided breathwork app that pulses lights to his Apple Vision glasses. 2035. Global supply chains stabilize after decade of virus variants. Shipping containers become mobile clinics. In rural Arkansas, retired trucker Jack shatters femur falling off autonomous tractor.
Clinic Container deploys sonic reduction. Low-frequency acoustic waves coax bone fragments to align like iron filings in a speaker experiment. It feels, he says, like standing next to a subwoofer at a country concert while someone twists my leg. Analgesia arrives as inhaled Allen 40, a non-opiate thalamic desynchronizer that produces wobbling déjà vu but minimal respiratory depression. He leaves Container on crutches, still humming Garth Brooks. Shift camera to Lagos, 2036, rainy season. Floods collapse footbridge, dozens with fractures. Local engineers hack cheap drones to deliver cold plasma jets. Sterilize wounds painlessly, prepping for splinting. Ultrasound-guided nerve blocks performed by AI voice assistant in Pidgin English. Small pinch now, bruz, hold steady. Community members trust the accent more than visiting NGOs. Pain, once colonial afterthought, now addressed in culturally tuned code. Now we step into 2037, where philosophy collides with tech. Geneva Convention updates. Unnecessary suffering now extends to untreated pain in detainees. Military field manuals include mandatory analgesia kits. Auto-injectors of fast-onset, short-duration AL6 peptides. Bone setting without at least local anesthetic is classified as inhumane treatment. The right to pain control becomes a humanitarian metric like clean water. Doctors Without Borders launch analgesia airdrop drones. But corporate boardrooms chase the opposite frontier, optimizing workers. An LA logistics company offers employees Pain Mute Fridays, wearable spinal cord stim patches that lower discomfort during warehouse peak. Broken fingers scanned at lunch get laser-welded microsplints. Pain dialed down, shift continues. Unions revolt. Healing needs rest, not suppression. Lawsuits regurgitate the old question. Is pain a warning we're morally obliged to heed? If we silence alarms, who protects the body from capitalism? Cybernetic augmentation adds another layer. 2038. Pro surfers install titanium-reinforced ulna preemptively. Surgeons cut healthy bone, swap alloy rods, reattach ligaments with synthetic screw anchors. Procedure done under full general anesthesia with zero recall. But critics say elective breakage offends Hippocratic ethos. Insurance denies, athletes crowdfund. The procedure skyrockets after first cyber surfer nails 120-foot Nazare wave, forearms unharmed. Younger fans ask in comment threads, wait, bones used to break? That sounds vintage. Neuralink companies pivot. Embed pain chips that translate nociceptive spikes into push notifications rather than agony. Feels like your phone buzzing in pocket. Early adopters love it until bugs cause phantom vibrations every minute. Firmware update fixes, but trust fractures. Still, the temptation persists. Why suffer if an alert suffices? Last checkpoint, 2040, Antarctica's McMurdo Medical Dome. Glaciologist slips on blue ice, suffers spiral humerus fracture. Evacuation impossible for months. Doc uses quantum splint, shape memory alloy lattice heated by embedded graphene ribbon. When chilled, lattice limp. When current flows, it tightens, sets alignment, then powers off, stays rigid. Pain? Hydrogen iontophoresis patch confuses sodium channels. Numb lasts 48 hours. Sophia continues ice core drilling next week. Penguins don't judge. We've toured a future where bone setting waltzes with lasers, stem cells, AI, and moral conundrums. Pain drizzles away in microdoses or vanishes behind VR curtains. Yet we chase new extremes that break us in weirder patterns. The eternal dance persists. Skeleton meets gravity. Gravity wins. Humans patch the cracks. And every generation asks how much pain is necessary. How much is cruelty? How much shapes identity?
So where do you plant your flag? Would you print yourself a new collarbone if it came with 0 nerve misfires? Would you let a neuromod chip silence pain forever at risk of forgetting caution? Tell me below. Your comments sculpt tomorrow's bioethics, one notification at a time. And if this 7-chapter, 17,000-word marathon story kept you company through sleepless nights or long commutes, smash that like so hard your screen considers a wrist brace. Subscribe so the next history dive materializes on your dashboard. And share the playlist with anyone whose childhood cast still sits in a closet like a plaster ghost.
I'll pack away the bone saws, sterilize the metaphors, and dim the OR lights. Until next episode, maybe sewage engineers of ancient Rome, maybe plague doctor beaks, you decide. Keep your skeleton inside the lines, respect the warnings your nerves still hum, and remember, history is a splint, holding the past in alignment just long enough for the future to set. Good night, and may all your fractures be merely theoretical.